Hello, wellness friends. Welcome to another episode of KAWP, and I'm pleased to be here today with Dr. Fadi Bacha. Dr. Bacha, you are the medical director of the Anti-Aging Institute and the Lexington Vein Institute. Is that correct?
Correct.
Or correct me on that?
Yes.
Okay. Tell me a little bit about your practice first, and then we'll kind of get into some of the specifics of what you've had so much success at.
Okay. So at the Anti-Aging Institute, we're a functional integrative medicine practice, focus mostly on wellness and health and trying to prevent disease before it's happened. But we do also a concierge medicine type of treatment. Our focus is mainly to allow patients to understand the process of being healthy, provide them a tool they need to succeed and address all their medical need. But we address it from a functional integrative part where we try to find the cause of the disease rather than just treating the symptom of the disease.
Why has medicine, just in general, I see more and more doctors like you who are kind of breaking away from the traditional hospital setting. And is it because you feel that we've been treating the symptom for too long? We've never looked at underlying reasons for disease, and that's more what you're trying to do?
Correct. So I do have a very successful and busy hospital practice.
Okay.
So I come from one extreme, and then when I come here is the other extreme. So I want my patient not to end up in the hospital practice that I have, where I have people on a ventilator or on dialysis or have extensive wound, a lot of time treating, heart disease, diabetes, and so on. So I like for the patient to be seen healthy and not have to end up like the unhealthy folks at the hospital.
I've talked to several doctors like yourself, and they seem to have a preference for this. Like they get to spend time with their patients, they get to actually get to know their patients. You don't have 100 patients that you're trying to see in a day. Is that something that you feel?
That's correct. So when I sign up patient for the concierge service, they have unlimited access to me. And they'll have my personal cell phone number. It's the same cell phone number that my wife and kids have, I swear. And we're in constant communication. So they need something on the spot. They have a question on the spot. Can I do this? Can I eat this? Can I do this kind of exercise? They can just text me or call me, and we will have a chit chat and address the need right away.
Well, that sounds invaluable to a patient to have access to their primary care physician. So I assume that you get a lot of positive feedback from your patients.
It has been very successful for me and very satisfying for me professionally and for my patient as well.
Okay, so you're located in Lexington, Kentucky. For those of you who may be looking for someone like Dr. Bacha, your practice, are you still accepting patients, or are you full? Or?
Yes, we're always accepting patients, and we're looking for new people that they want to continue to be healthy.
Okay, so if you're looking for someone like Dr. Bacha, just click the description and we'll include all of your information, contact information, and things like that below, and you can talk to Dr. Bacha yourself. Now, the reason I'm here today is you have had some extreme success with something that's kind of the trend right now, and that is using the semaglutides as part of a weight loss program. So what I want to ask you is, when did you kind of start with the semaglutides here in your practice? And then we'll talk a little bit more about what your specific protocols are and some anecdotes about some extreme weight loss in some cases with some of your patients.
So part of the integrative functional medicine focus has always been, preventative health and treatment of obesity. So even before the semaglutide and the similar medication came out, we've always been treating obesity with whatever tool that we have, whether it's a diet or exercise, supplementation, lifestyle modification. We also used to use a older GLP-1 inhibitors called Victoza, compounded one. We use that for weight loss on particular type of patient that qualify for that. And then the revolution happened when Ozempic or Wegovy came around, and as you were aware, it was intended to treat diabetes, and then they found out that all the people that took those medication have weight loss. So then that's when the Wegovy was commercialized and became available as a weight loss medication. And unfortunately, because of the shortage in the increased demand for these kind of medication, there become a shortage, national shortage on availability, and pharmacy were allowed to compound those medication. And then, of course, we started added it as an adjunct to our weight loss program with a great success. But you have to keep in mind, not all patients are the same, and not all dosage will work on the, all the patient. And there are some patients also will not be a good candidate for these drugs. So you have to talk to the patient, take good history, do an extensive lab work, and then a lot of time I do a head start, and then we'll move on to see, okay, how can we maintain on the success that we had.
Well, I just full disclosure, a couple of my friends see you as their primary care physician, and they have tried, they've asked me for advice and things like that, and of course you give them, a lot of patients, the advice, but a lot of people can be motivated for a little while, and then the motivation tends to wane, and the success starts to kind of wane as well. But in both these instances, and they're willing to do testimonials for you, by the way.
Great, thank you.
But they've lost 60 and 80 pounds respectively, which is far more than the 14% of the body weight that's typical with these type of drugs. So you're obviously doing something that's a little bit better than the norm. Is there something that you're doing that you can tell us about that's a little bit different, or it's just kind of
yeah? So I have the tool first, being the knowledge internal medicine. I have the tool to kind of look at the picture from above, not just looking at it directly. And I start all my patients with a good screening on everything that could be going on with them. So hormonal imbalance can play a big role in that. Second, we do a in-body test, so we know the body composition, how much fat you have, how much skeletal muscle do you have. And looking at all the other issues that could be contributing to the obesity. And then, as I said, kind of a dose titration depending on the patient response. All the patients, not everybody will have the same success that your friends have, but pretty much, been successful across the board and helping people getting rid of their obesity.
Well, people ask me, what should I do? Lots of places have now started opening up clinics that are kind of geared toward the medication. But what I tell them is you need to really find a physician to oversee your program, because not only are they going to oversee the administration of the medication, but they're also going to be able to look at your overall health and see if there's some other things that are contributing perhaps to how you're feeling. And hormones clearly is a big part of that.
Correct. So that's why I said we're a functional integrative medicine. So we look at the whole picture, not particularly just the obesity part. So are you insulin resistant? Do you have high blood pressure? Do you have high cholesterol? Do you have fatty liver because of the obesity or the high cholesterol? So all these need to be treated combined, not just as we're gonna give you a semaglutide, here's your dose, I'll see you later. I'm pretty sure there's a lot of other practices that do the same thing that I do. So I always encourage a patient to find somebody who is, knowledgeable in medicine, approach the patient from the integrative functional approach, where we take the whole body as a whole and not just concentrate on individual problem.
For those of you out there that are watching this, take this as a cautionary tale, because a lot of these clinics have now popped up that are offering these drugs, but they're not necessarily overseen by a medical professional. So please, if you're considering this, consult with a physician before you engage in anything like these drugs. Well, it's kind of changing the whole map of healthcare in the United States. I think I read somewhere that 74% of the population of the United States is now considered overweight or obese, which is just shocking to me. And I guess technically I would even be overweight based on some of the old height weight charts. Mm-hmm. But the medication is clearly changing the landscape on some of that. But like with all medications, there can be some side effects to that. And when people ask me about the medication, they're always saying things like, do I have to be on it for the rest of my life? So could you address that if someone has to be on it for the rest of their life?
Just you brought up a point as far as the obesity and the BMI. And the BMI sometimes not very accurate in addressing, whether you're overweight or underweight, because it doesn't actually look at the body composition, muscle or fat. So, I give you a football player from UK, and based on BMI, he will be obese, but this guy have, 6 or 7% body fat. So the BMI is not a true reflection. It probably will work on 92, 93% of the population where, not everybody is, fit and have the right physique. And that's why, a lot of my patients, I start with doing a body composition, so I know where to start. And then a lot of time when they lose the weight, they lose body fat, but they also lose muscle weight. And I tell my patient, don't worry about that. The main goal is to get you lighter, because when you're lighter, be able to exercise better.
Right.
And your trainer or yourself be able to do more exercise and build those muscle back up once we get done with the phase 1, which is weight loss. And you are correct. I mean, if you're just taking the medication, you got to lose weight while you're taking the medication. Mm-hmm. Unless you do a complete lifestyle modification, then the weight will come back as soon as you stop taking the medication. We have been able to find some ways into helping patients change their lifestyles and maybe do a maintenance program where they keep the weight off and not necessarily take the medication all the time. So maybe able to taper the dose back, stretch the dose, or maybe give them a break or a holiday and then go back on the medication. So I kind of experimental with a lot of different ways with trying to find which one work better for a particular patient. And when we start, usually as they're losing the weight, and usually patients feel ecstatic that they are able to wear clothes they haven't been able to wear for a long time, or they having to buy a whole new wardrobe, and they don't want to go back to the old way. So I start introducing some good tips about how to do proper diet. And whenever people hear the word diet, there's kind of block. Hey, I don't want to.
Most of them have been on a diet all their lives.
I like food. Well, I like food too. Everybody likes food. It's just you need to know when to eat it, how to eat it, and how much to eat. And I think the reason these medication has been successful, because they allow you to eat what you like, is just it really blocks your appetite. So you order the big pizza, but you're only able to take 2 bites out of that big pizza, and the rest you're just looking at it, admiring how good it looks. But you're not be able to eat anymore.
That's a great point you just made there. I think a lot of people misinterpret the fact that an appetite suppressant or something, that they don't want to eat. I think people do want to eat on this medication. They're not nauseated by the medication. It's just that when they're eating it, they get full much quicker.
Correct.
And they're satisfied from what they've eaten, and then they maybe can take some pizza home with them and have it again tomorrow, or maybe again.
That's correct. So the way it works to slow down the gastric emptying, and that's usually produce satiety and then send the feedback to the brain that I'm full. But that's why also we have a lot of the side effect that goes on, which is mostly people have nausea or severe heartburn or sometimes constipation. So most of the side effect is usually GI side effect. Of course, one of the most extreme side effects is a pancreatitis. It happens about 1 every 25,000. Pancreatitis could be serious, so that's why you need to be screened. Now, if you have a history of pancreatitis, or if you have a history of thyroid medullary cancer or pancreatic cancer and so on, you're not going to be a candidate for these medication, and we probably will use something else. But other than the GI side effect, the medicine has been fairly tolerable. And then that's why the dose titration is very important, so you can avoid all these GI side effects. And sometimes switching medication between semaglutide or tirzepatide will help to negate some of these side effects.
Do you think we're in the early innings of a revolution in medications that help people with
I think so.
weight loss control? Because I'm hearing that there are new medications in phase 3 trials that are coming.
So, the semaglutide block one of the receptor, tirzepatide came in and block 2 receptor. I heard there's one block 3 receptor. So, yes, we are getting better and better with time. And, I think these medications going to help a lot with the obesity issue that we are facing. They're not going to be the perfect solution unless we change our lifestyle, what we eat, how we eat, For instance, the type of food that we have, unfortunately, a lot of our meat and produce are full with hormones and pesticides and so on, and that's a whole issue by itself that kind of...
It's a whole other podcast.
Yeah, exactly. So, and I'll try to get my patient move into organic vegetables and try to get a hormone-free meat and so on. So when they are not taking the medication anymore, they are living a healthier lifestyle.
So if you look at our ancestors, let's go back maybe 100 years, people typically weren't overweight. Then you started getting sugar, cereals, soft drinks, things like that. And then insulin resistance, I think, sort of started then. So you're saying if we kind of go back to the foods that our ancestors were eating, which are whole foods, whole grains, non-antibiotic derived.
We did not have the high concentrated fructose syrup that's in everything right now. It's all GMOs, absolutely. And then I'm pretty sure our ancestor ate more than we did and did not gain that much weight. Also, I think it has a lot to do with activity starting from youth. So if our young one, a lot of time, are sitting behind a tablet or behind a computer and not being physically active, like our ancestor used to be, and running in the field, using steps rather than elevators, walking to places, riding the bikes for places, and unfortunately, you don't see that more often, and need to start early, get the body to use to that high metabolism rate, rather than just once you hit 30 say, oh, what we're going to do now.
Well, now you've got phones, computers, people are looking down all the time, they're not out doing anything. I do appreciate the fact that watches and things like that seem to stimulate people if they're trying to count their steps and things. I know people that will look at their watch and say, I'm 1,000 steps short, so I'm going to go ahead and take a walk around the block. So there is some benefit to the technology, but I think the other side of it is it's really made us a lot less active, and we're much more sedentary than we used to be.
So I try to tell my patient that it's a lifestyle, and you have to integrate activity into your lifestyle. So it's no different than you get up in the morning, you brush your teeth, you use the restroom, you eat your breakfast, and sometime during that routine, whether it's eating breakfast or eating dinner, it's going to be some sort of physical activity. Whether you're going to be taking a long walk, we're going to go hit the gym, lift weight, whatever, but that's going to be part of the routine. Same as it's no-brainer that you're going to brush your teeth, take your medicine, eat your food, do some exercise.
Well, I try to absorb a lot of content, and they're talking about sleep as one of the pillars of your health. I don't think I really, as a young person, adhered very well to sleep hygiene. It was late nights, kind of.
So you tell us you were a party guy, huh?
Well, I think everybody in college probably spent a night or two not in bed at 8 o'clock like I am now. But I find it fascinating that a lot of what we're finding is revolutionary is really not revolutionary. It's just kind of common sense. If you just think about what people have done for a really long time and what we're doing now, and you should say we should extrapolate from what they used to do to what we're not doing now, and we're probably going to be a lot more healthy.
Right. So, that's 100% right. So weight loss is all about caloric deficit. If you don't put the weight to begin with, you don't have to worry about caloric deficit. But let's say you're past that point, you already put the weight on, the only way to reduce the weight is to go to caloric deficit. So you heard about keto diet, and you heard about intermittent fasting diet, and you heard about taking phentermine and taking this. They done study, compare them all, and at the end you may lose a little bit faster with keto, or may lose a little bit faster with intermittent fasting, but at the end, over time, all of these curves meet together, and it's all about how much calorie do you eat. So that's why I think these drugs have been able to have people to achieve their goals. The reason also they're effective, people see the results very quickly.
Right.
And so it makes them more prone to continue using these drugs, and probably follow doctor recommendation versus a slower mode of weight loss that usually gets you frustrated.
Well, I've talked to several people who've been on the medication, and one of the things that I find is they say, well, number one, Kelly, I'm not on a diet. I'm not, Dr. Bacha didn't say you can't have this and this and this. Basically, he says you can eat what you want to eat, it's just you're not going to want to eat much. And I'm losing the weight. Therefore, I'm more motivated to work out. I'm more motivated to do healthier things just because I'm excited about how this is working for me.
And then how, every time they come in, I can see the sparkle in their eyes. They're happy when they get on the scale, or when I do the in-body test and see the reduction in their fat content. And that will allow me to start introducing, healthy tips about diet. Say, hey, what about, what kind of snack do you have? So we'll talk about it, and then, what do you think about introducing maybe some berries instead of these snacks? Yeah, I like berries. Okay, well, why don't you get rid of the potato chips? Don't buy them.
Right.
So when you look for them, they're not there, and just get some berries. And I find probably, I'll say 80-90% of my patients a lot of time follow these healthy tips and go with it.
Most of the people that I see are older people. They're 60 to 90 years old. Some of them have had a lot of injuries. Some of them have chronic joint problems and things. So they're saying to me, well, I really can't do a lot of exercise. But I always come back and say, well, 80% of what you're trying to do is diet.
100%.
And if you can alter that, and you take some stress off the joints, if you take some stress off of your spine, then maybe we can do some things that you didn't think you could do before, like a recumbent bicycle, or perhaps something where you're doing something in the water that takes some stress off your joints. So not only is it helping people with the weight loss, but it's also helping them with some of the chronic morbidity issues that they can address as they've lost the weight.
Correct. Well, and also you have to address the obesity as a serious health issue. Most people come in and worry about how they physically look. I look at them and I worry how they look on the inside. One of the measurements that I do is I measure visceral fat. So my machine allows me to measure visceral fat. So what's visceral fat? Visceral fat is the fat around your organs, inside your liver, around your intestine. Well, unfortunately, that's the fat you don't see, but that's the most dangerous fat. That's one that makes you insulin resistant. That's one can be leading to you to have a heart attack and stroke in the future. That's one that causes you to be in higher inflammation state. And then, unfortunately, that's the hardest fat to lose, because that will be the last fat that you lose after your BMI go back to normal. Then you start losing some of that visceral fat. So I look at the patient and I say, okay, how much visceral fat he has, how much work I need to do, because I don't want, going back to hospital practice, I don't want that patient be on that dialysis machine in the future.
So if a patient is losing subcutaneous fat, or the fat that we kind of see underneath the clothes, is it fair to say that they're not yet losing visceral fat, or is there some loss of visceral fat?
Maybe there's some loss, but when I look at them real time, I see the first thing that comes off is what you see, but not one you don't see, which is the visceral fat. That's the last one to go. Same as the abdominal fat. People who are bodybuilders know that you lose fat everywhere, but the last one you have is the one that show up your six-pack, and those are the hardest to lose. And the same thing in there, the visceral fat is the one behind that six-pack, and that's one very hard to lose.
Right. But it is possible.
Yes.
Okay.
Yeah, we had a lot of people successfully drop their visceral fat by 2, 3, 4 numbers. Some of them return to normal.
Great. Well, is there a threshold, like as you're losing the subcutaneous fat, that then the visceral starts kicking in? Like if you get your BMI down under, let's say 20, 15, and then some of the visceral fat starts coming in? I
don't want your BMI to be under 15. I think that'll be too low. But usually after you start dropping about 30% of your percentage body fat, so once you start to drop to a percentage body fat below 24, I'll see the visceral fat start to also go down.
That's obtainable for most people then, I think.
Absolutely. So the healthy body fat for a male should be around no more than 16 to 18%. For female, a little bit more than that, about 18 to 20%. And most patients that I see, they come in a percentage body fat anywhere from 30 to 50.
Do you adjust for age and body fat?
Unfortunately, I don't think there is any adjustment out there, not that I'm aware of, as far as age.
Sorry.
Yeah.
Yeah. Because my older folks tend to, we've had a lot longer to put on the body fat. So.
Yeah, well, it is, and also it will take them a lot longer to get rid of it. But I tell patient body, the Rome wasn't built in one day, and neither was your body. So you just got, you didn't do it all in one day, and you're not going to lose it all in one day. So you have to be patient.
Well, listen, I know you're a busy physician, and I don't want to take up any more of your time. But thank you for taking the time to talk to us about the revolution in weight loss. And again, any of you out there that are interested in talking to Dr. Bacha, clearly you can see that he has a good practice and knows what he's talking about. So get in touch, and hopefully he will keep you out of the hospital as well. Thank you so
Thank you very much.
much.
I appreciate it. Thanks a lot.